Hi everybody, Dr. Hall. I finally remembered to turn off the camera so that my head wasn't in the way. We're going to talk about the last section, pain and orgasmic disorders. So we'll start with the pain disorders. Now, normally, if you're doing things correctly, sex should not be painful. Unless you're intentionally trying to cause somebody pain, sex should not hurt. Okay, so if you're having pain with sex, then there's something going on that needs to be addressed. The one exception, potential exception being in the beginning in a female-bodied person with rupturing of the hymen, right? Okay, so if there is pain, so in a female-bodied person, we call this dysperunia, which is a strange word. First of all, we need to make sure there's not an infection, either out on the vulva or inside the vagina or up in the cervix or uterus. Certainly pain can be due to an infection, so that's one of the things that we want to exclude. Vulvar conditions. So if there's some type of strange rash or irritation on the vulva, then that can cause pain as well, just like a rash somewhere else on your skin. So that also needs to be evaluated and excluded. And then another potential cause of pain with sex would be trouble with the hymen. And so the most common one we see is this septate hymen, which is this one over here, where you have this band of tissue that goes across the opening of the vaginal introitus there. And so sometimes people who have this anatomical variant will not be able to have intercourse at all, like they just won't be able to allow anything inside the vagina. Or sometimes they will if it's kind of over to one side, but it'll be really painful. So if somebody has this, it's actually really simple to treat. We numb it up in the office and trim it off. And that might sound kind of horrible and brutal, but it's actually really well tolerated and people do just fine. So that's a possible cause too. The other thing that we see quite frequently is ovarian pain. So gonads are sensitive, right? If you walk up to a male-bodied person and you kind of bop them in the scrotum and, hit them in the scrotum, that's going to hurt. And so depending on positioning during intercourse, sometimes as if the person with the penis or the phallus is thrusting, that can kind of bonk up against and hit the ovaries. And this is often related to positioning during intercourse. So the image on the left, what we see on the bottom is there's a female-bodied person laying on their back. So we can see the uterus and see the ovaries are kind of a little bit behind the uterus. And in the distance here, you can kind of see, like, here's their leg, right? So this is the female-bodied person's abdomen, and this is their buttocks here. And you can see as the male-bodied person is putting the penis inside the vagina, it's well away from the ovaries. In the rear entry position, however, so here's our female-bodied person, here are the buttocks, right? Here's their belly down here, here's their leg. In this position, however, you can see how the angle has changed. And so it's not uncommon at all in a rear entry position for the penis to kind of be hitting up against the ovaries. And that often feels like a oof kind of pain. It might make you feel a little bit kind of sick to your stomach, kind of make you cringe inwardly. And this isn't abnormal. It's just you're bumping the ovaries, and gonads are sensitive. So there's no specific treatment needed for this except stop bumping the ovaries, right? So adjust your position so that that doesn't keep happening. Another cause of female pain with intercourse is something called vaginismus. And what this is spasm of those pelvic floor muscles that kind of just squeezes tight the outer vagina. And it can make penetration painful or sometimes even just not possible because it's just like, you shall not pass, right? It's just totally closed down and clamped down. This sometimes develops in response to a painful condition. So sometimes someone has a really bad yeast infection or some type of other problem, and this develops as a secondary response to that. It can also happen with fear and anxiety. So the the treatment is going to have to be directed at whatever the causes are. But again, sometimes even if it started with an infection, sometimes it can be kind of a self-perpetuating thing. So if there's an underlying problem, we're definitely going to address that. But what we can also do is something called Kegel exercises. So Kegel exercises are where you voluntarily practice contracting those pelvic floor muscles and you get voluntary control over them. Because what's interesting is that as you get voluntary control over contracting a muscle, you also get improved control over your ability to relax that muscle, which is what we need to have happen to treat this. Sometimes we'll also have someone work with a gradual introduction of larger and larger dilators to help kind of get used to having larger things in the vagina. Or there are even physical therapists who specialize in pelvic floor conditions who can be enormously helpful in treating vaginismus. This is just some more information about those Kegel exercises. And so, if you can establish voluntary control over these muscles, then it's also easier to voluntarily relax them. So there's some data that suggests that if you have really well-toned pelvic floor, or pubococcygeus is one of those muscles, so sometimes you'll hear about the PC muscle, that it can perhaps maybe improve or facilitate orgasm. So I don't know how well that's been studied. That's an idea that's been floated out there. Now, traditionally, the old way that people taught female-bodied people to find these muscles was to start peeing and then try to stop peeing midstream. This is not a really good thing to do for your bladder. So in general, it's better if you can just try to squeeze those muscles around the lower vagina and kind of practice that. You can insert, a pinky finger into the vagina and work on trying to squeeze it. That's how you can identify those muscles. And in general, just be sure if you're doing this that, you shouldn't be clenching your buttocks at all, right? These are different muscles, and it can take a while to get the hang of it. Another pain disorder that happens in female-bodied people is something called vestibulitis. So itis in medicine just means inflammation or irritation. And you might remember that that area between the labia minora is called the vestibule. So these folks have some significant pain, usually kind of a burning pain present in the vestibule with attempts at penetration. And there's often some very specific spots, and we can see that in this individual here. So what they've done is they've kind of pulled aside one of the labia minora. I'm just going to give you some landmarks. This is the opening of the vagina here, and it's kind of irregular in appearance because of the hymenal remnant. But what we can see over here, see this red spot? See how red it is? And maybe yellow will show it better, right? So we have this kind of red spot over here. This spot is really sore and tender to the touch. And this is not a very well understood condition. It seems to be associated with the inflammation of the nerve endings in this region. And then because it's painful, this can end up causing avoidance and vaginismus, which we just talked about. Sometimes this seems to be preceded by an infection, like an infection happens first that we think then causes the irritation of the nerve endings. So treatment for this varies. So sometimes we'll use pain medicines or little topical numbing creams or gels, and there are some prescription medicines that help with the nerve endings that we can also use. So that's vestibulitis. For male-bodied people, pain disorders are really uncommon. There is a rare one called postejaculatory pain disorder, where they get spasm of the ejaculatory muscles, so all along the vas deferens and the columns of the penis, that happens either during or immediately after ejaculation. It can be very painful, but it usually resolves in a few minutes. We don't know really what causes it. It might be similar to vaginismus in female-bodied people. And so the treatment really varies. Again, it's very uncommon, but I just thought I would put it out there. So our last category is the orgasmic disorders. So in male-bodied people, usually what we're talking about is premature ejaculation. So this kind of lack of control over ejaculation, often resulting in ejaculation that occurs very soon after intromission, which is another name for penetration. So very soon after they put the penis in the vagina or the anus. And we have to also keep in mind that our idea about what is normal may not necessarily be in line with reality. So the average time from intromission to ejaculation for male-bodied people is about 3 minutes, which is not very long, right? So if you're like, oh, I can only last 5 minutes, well, that's actually longer than average, right? But perhaps you've been watching a lot of porn with these people who are professionals, right? And they can keep going for 20 minutes, which is not typical or normal human, right? These people are Olympians at sex, right? They're not normal people. But this can be really distressing to the person and their partner for sure. And there's lots of different causes. So the younger you are, the more likely this will happen. The less experienced you are, the more likely this will happen. There's also an impact of what's called conditioning, right? So the body gets into habits of things. So if most of your sexual experience has been quickly trying to masturbate in the bathroom, and get it all done with as soon as possible before your siblings are banging on the bathroom door, and you've kind of trained yourself to go through this sexual response cycle really quickly, then that might be part of the issue, right? You've trained yourself to be fast. There is some evidence to suggest that maybe people who have premature ejaculation have more sensitive penises, so that's a possibility as well. There are a lot of different treatments available, and those are discussed in detail in the book, which you can refer to. But really quickly, sometimes wearing a condom by decreasing sensitivity can give you what you need to last a little bit longer. Pre-session masturbation. So if it's the second go round in a period of time, usually it takes a little longer for people to reach orgasm. So there's kind of a famous scene in the There's Something About Mary movie about going out with a loaded gun, which there's a link down there that you can look at. There's some different techniques that you can use. There are medications that you can use that you can read about on your own if interested. So on the female-bodied side, usually in terms of orgasmic disorder, what we find is anorgasmia or lack of orgasm. So anywhere from 15 to 8% of female-bodied people report never having an orgasm. It's associated with negative attitudes about sex, and which if you never orgasm, maybe I don't know which one came first, but also higher levels of discomfort with and communicating about sex, and more likely to feel guilty about sex. So we've talked about how all of those things can really interfere with the sexual response cycle. So it could be due to those internal factors, or sometimes it's due to insufficient or inept stimulation by their partner, right? Sometimes what their partner is doing is just actually not pleasurable to them. It's also possible that for some people, this is normal and just how their bodies are, right? Maybe some people just don't orgasm. That's a possibility we have to consider. So there are lots of different treatments out there. So certainly doing a lot of cognitive behavioral therapy, looking at attitudes about sexuality and sex that could be harmful or interfering, and replacing them with some healthier, more sex positive attitudes. Couples work on communication and pleasuring each other. Masturbation to find out what actually feels good to kind of learn your body, and education are potential treatments. So in summary, right, so we've talked about all the factors that go into the regulation of sexual behavior, both internal and external, including those social norms and what the actual behaviors of college students are. When we talked about sexual function, we talked about the Masters and Johnson's 4-stage model and all of the different physical things that are happening along the way. And then Kaplan's 3-stage model, which incorporated that desire phase that precedes the other elements. Then in terms of dysfunctions, so remember, asexuality is not a disorder. And for hypoactive sexual desire disorder, the medication proved to be underwhelming. Arousal disorder in women would be lack of lubrication and vasocongestion, and in male-bodied people would be erectile dysfunction, and we talked about the main causes of that in all male-bodied people, but particularly young men. Pain disorders are much less common, and they could be due to infections or vulvar conditions or things with the hymen. Ovarian pain, ovarian cysts can cause this. And then the less common things like vaginismus, vulvar vestibulitis, and in male-bodied people, post-ejaculatory pain disorder. And then the orgasmic disorders. So premature ejaculation is more common in male-bodied people, or premature orgasm, and then lack of orgasm is more common in female-bodied people. So that's it for the sexual dysfunction lecture. Thanks.